Hello everyone. This is Lisa Lanasa with diaVerge Diabetes, and I am joined here with Allison Herschede, and we are going to be talking about the 5 most common, most prevalent pregnancy myths and how we can dispel those myths. So, Allison, thank you so much for being here. I appreciate it. Now, pregnancy is a topic that is near and dear to your heart. I know, diabetic pregnancy, I should say, especially. Now, for those who might be joining us who don't know about you, can you tell us a little bit about yourself and about your experience with type 1 diabetes and how you became interested in diabetic pregnancies?
Yeah, well, I lifelong type 1. Basically my entire life since I was 18 months old. And, from when I was a little kid, I was always warned of not having children because they would have birth defects. They would be huge. It could kill me. Everybody told me about steel magnolias and, Shelby died from having a baby and you're diabetic, and that could be so dangerous. So I always wanted to be a mom. And growing up, technology advanced, and in the year 2000, I went on an insulin pump. And I was told, oh, you can have a healthy pregnancy. I was giving the typical advice of eat the carbs and bolus for them, and you'll be fine. Mm-hmm. Then I became pregnant for my first daughter when I was 24. And I actually had a pretty healthy pregnancy, a lot of low blood sugars, a lot of insulin, but I was able to keep my A1C in the 5s. And during that time, I had a CDE who would call me every 2 days. And she would call and we would talk about my numbers, and she would adjust my insulin. She would give me advice. And I think that's really when the seed took of wanting to do this.
And for those who don't know, a CDE is a certified diabetes educator. And she was really your inspiration, wasn't she?
Absolutely, yes. And a funny story, I actually came across her the other day after 16 years. I've been looking for her for many, many years, just to thank her, to let her know you were an inspiration to me. And I could never find her. I looked in the CDE list. I just did searches, found nothing. And then all of a sudden she popped up in my LinkedIn, people you may know. So we caught up.
So it was meant to be. That's great. I love that. Oh, so glad that you were able to reconnect with her. Now, as a result of that, you became a registered nurse and a certified diabetes educator yourself.
Yes, this was a bit later down the line. Honestly, this was after I had found Dr. Bernstein, after I had found type 1 grit and low carb. I wanted to spread the word. And I knew that people weren't going to just listen to some girl on the internet. So I needed those letters behind my name. Though you seem to have pulled it off pretty well.
I was just going to say the same thing, actually, but so, and you have been really involved in type 1 pregnancy groups for years.
Long time. I joined a group. It was a Yahoo group back in 2004 called Positive Diabetic Pregnancies. And we eventually morphed. I took over moderating a couple of years in. And then we moved over to Facebook after Yahoo groups basically became obsolete, and we changed to the name Positive Type 1 Diabetic Pregnancies, and we're still very active. And then I also admin Grit Pregnancies, which is a pregnancy group for those following the Type 1 Grit, Dr. Bernstein, low carb lifestyle. And that's for any type of diabetic.
Right. Oh, that's fantastic. And you have 3 children, correct? And the last of which was a low carb pregnancy.
Yes.
And can you just mention for a minute before we get into our 5 myths that we're going to cover? I think this is really important. Can you mention the differences that you experienced between your first 2 pregnancies and your third?
It was night and day. It was just totally different. With the first, it was up and down and tons and tons of low blood sugars, trying to stay in those tight parameters. I was given the parameters that I needed to be between 60 and 90 fasting. I needed to be less than 120, 2 hours post meal. And how do you do that? Eating carbs.
Right.
It's almost impossible. So I was taking tons of insulin, constantly correcting, constantly going low. I took well over 100 units at the end. My insulin to carb ratio was down to 1 to 2.
Wow.
I gained more weight.
I was going to say the weight issue is a really big thing with that as well, because you're constantly correcting, you're constantly eating to avoid these lows.
Yeah.
I experienced the exact same thing with both of my pregnancies. So just extreme.
I know you told me in the past that yours were standard American diet, I guess. I don't know what kind. I guess it's not American. I'm not sure.
Well, yes, standard American diet. My first daughter was born in the United States. My second one was born in Argentina. So, but the standard of care was pretty much the same. And, I was told that I had to keep my A1C around 6 and not really given any tools to do so. And I had lots of highs and lots of lows and ate a ton and gained a ton and, healthy babies, but, still, I think it was just a lot of undue stress.
Yeah. So the low carb baby, I took half the insulin. I think at the very end, at my height of insulin resistance, I was at 50 units a day.
Wow.
A lot less lows. I still have lows because, that insulin sensitivity changes just so rapidly. Around 7 weeks, every time I would see this huge drop in insulin needs. And I called that period the lows because it was just, I felt like I was low all the time. And then again, 34 to 36 weeks, I had a big drop in insulin needs. So there were lows, but they weren't the scary lows like I had with my others. Well, especially with my second baby. When I was 28 weeks, I had this incident where I was so low, I was completely incoherent. The paramedics had to come. It was terrifying.
Oh,
so,
wow.
Yeah.
Well, I'm so glad that the third one was better.
Yeah.
And now you can teach everybody everything that you've learned, both from personal experience and through your education.
Yes.
So, but now I need to transition at some point here to talking about this book that you are writing.
Yeah.
So I'm really, really excited for this. I was happy to be able to check out the outline, and every single topic I was looking at, I was just thrilled, saying, oh my gosh, I wish I would have known about this. Oh, this is perfect. This needs to be included. This is great. So all of this experience has kind of been the catalyst to writing a book about type 1 pregnancy.
Yeah, honestly, the catalyst was the groups that I admin. I would see the same questions over and over and over. And I thought, the doctors are not addressing these questions. They're not telling you this might happen and this is normal, or, how to deal with certain things. So I wanted to touch on those topics that I had never seen mentioned in other pregnancy books. I know that there are, I think, 2 popular ones right now, type 1 diabetes and pregnancy. They're both very good. They both have a lot of information. And they sort of touch on low carb, but I really wanted to put in the low carb focus and talk about the safety and the difference you can have in your control with low carb.
And I really think there are so many unknowns during pregnancy to begin with. Having that basis of knowledge just gives so much empowerment and more control over the situation that you really, at least the first time, you don't know anything about. So yes. I think that's incredible to be able to empower, type 1 women.
Yes.
I have a little dog too. He's under my desk. So
they seem to always be active.
Of course. You get on a call and they're always barking. That's how it goes. No worries. Okay, so first of all, before we finish that topic, I know it is an incredibly, incredibly involved book, and the detail that you're putting into this is unlike anything I've seen outside of Dr. Bernstein's book. But when are you planning on completing it? When do you anticipate it's going to be done? I should put it that way.
So I worked pretty hardcore at it for about 6 months, and then there's been a lull since this whole COVID thing. And I just got started back on it. I've gotten some good work done. So I'm hoping by the end of the year, by December. I would say I'm 3/4 finished at this point, if not a little further. I'm just to the like last 4 weeks of pregnancy, and then I'm going to talk about postpartum and breastfeeding.
Oh,
and just,
fantastic.
oh yeah,
That is so great. Well, definitely, I want you to keep us updated. Post progress,
yes.
progress information on it. So we would love to hear about that. Okay, so what everybody has come here to hear are the top 5 myths of diabetic pregnancies and what the truth is. So let's jump into that. The big elephant in the room, I think you've already talked about that, or you touched on that, is that all type 1 pregnancies are high risk, or the belief that all type 1 pregnancies are high risk, and the perception that type 1 or any diabetic women just shouldn't have children. I think there's still a huge myth about that. I was told the same thing, saying you got to think carefully about this because of all the problems, and it's not recommended that you get pregnant. So,
I was told that even when I became pregnant with my first, my A1C was at 8.7, and my endocrinologist just was, no, you do not need to get pregnant. You're going to have problems. And I found out that day I was pregnant. So yeah, I made some drastic changes. I had my A1C to 6.3 by the time I was 6 weeks pregnant. I mean, that rapidly. Incredible. I was able to get it down quickly, but yeah, the fact is there is risk if your blood sugars are high. Mm-hmm. High blood sugars are what cause the risk. Diabetes doesn't inherently make you high risk. It's the blood sugars. I know some people have suggested that maybe the autoimmune component could be part of the risk, but from my knowledge, autoimmune is diminished in pregnancy. A lot of the different autoimmune diseases, you see a lot less symptoms during pregnancy. So it's the high blood sugar. Mm-hmm. And I know many doctors will argue that even with tight control, we still see stillbirth, we still see deformities, we still see, all these different problems. But I've read those studies, and the issue there is that they're calling 6.9% tight control.
I was just going to say, what on earth is their parameter for tight control? That's the huge question here. So.
I think one of them said 6.5%, and that is still much more than normal. A normal A1C is, 4.6 to 4.8.
And you're talking a normal non-diabetic blood sugar level.
That is the goal, non-diabetic blood sugars. And it is possible with Dr. Bernstein. So, yeah.
Oh, that is so interesting. Well, and we all know from personal experience that many times doctors are shocked at the results that we can achieve because they haven't seen it anywhere else.
Yeah.
So
my last MFM, the maternal fetal medicine doctor, he said I was his poster child. He's like, you can manage your own diabetes. He actually let me fire my endocrinologist who was not on board with low carb. He's like, you've got this. You're my poster child. You can do it. So I ended up managing my own diabetes. And yeah, he told me that my A1C was better than his.
Yes. There was one time recently that my A1C was better than my husband's, which was kind of fun.
Love it.
Since I'm the type 1 and he's not. But anyway, okay, so it is the blood sugar level that creates the risk rather than diabetes itself.
Yes. And I'm touching on this a lot in the book on the reasons for the risk, not just, well, you're at risk for this. I'm telling you, you're at risk for this because, for instance, polyhydramnios, that's when you have too much amniotic fluid, which is common in diabetic pregnancies. The reason for this is when your blood sugar is high, baby's blood sugar goes high. So it starts urinating more to push out that glucose, and it makes more amniotic fluid. So there is a reason behind every single one of these things that we see. The high blood sugars deteriorate the placenta. The high blood sugars, contribute to preeclampsia. It's all blood sugar.
See, and those are the things that nobody tells you.
Right.
So thank you for being our voice of reason here and being able to share this information, because I think there's so much fear too among
Yeah.
diabetic women when they are considering pregnancy or when they discover they're pregnant and they don't know what to expect, like I said. So,
Yeah.
okay, so that was our number one, that diabetic pregnancies are inherently high risk, and they are not. It is the blood sugar levels that create high risk rather than diabetes itself. And number two, that mothers need to eat carbs because babies need the carbs to grow.
Oh, that is
Wrong,
huge.
wrong. So tell us about that a little bit and what your experience has been.
I hear that over and over and over from the MFMs, from the OBGYNs. Your baby needs carbs to grow. Your baby needs carbs to grow. And Dr. Bernstein, his answer to that is that's utter nonsense. Baby needs glucose to grow. And if you are a type 1 diabetic and you have ever forgotten your insulin injection, your Lantus, your Basaglar, whatever, your basal insulin, you'll see that your blood sugar starts climbing whether you eat nothing or not. And that is because your body is making glucose all on its own. In the liver, it's called gluconeogenesis. And it doesn't matter whether you eat or not, your blood sugar is going to go up. So the fact is, you're going to have glucose. As long as you have glucose in your blood, your baby is going to get all the glucose it needs. Even when you're low, baby will take the glucose even to your detriment. Baby's going to get what it needs. So the focus is nutrition. It's, adequate protein, adequate micronutrients, the vitamins and minerals. Baby doesn't need carbs. Baby needs glucose.
And our bodies are amazing physiological machines that are able to create what we need without this food group. There aren't, as Dr. Bernstein likes to say, as we all like to say, there are no essential carbohydrates. There is no such thing as an essential carbohydrate.
I love that quote. Yes.
All right. Well, fantastic. So mothers do not need to be consuming carbohydrates during pregnancy, and the baby will get everything that they need for growth from the protein and the fat that the mother eats, because
and the vegetables.
And the vegetables, of course. Okay. So number 3, we have early induction will be necessary or is mandatory.
One of my biggest pet peeves.
Now, how much of this comes from, well, I mean, this is all misinformation. That's why we're addressing this. These are the myths. But this is one area where I feel mothers are really bullied.
Oh, yes. Big time. So most doctors, not just in the US, worldwide, will say you're diabetic. We need to induce 37, 38 weeks. Because your risk of stillbirth, the farther along you go, the higher your risk of stillbirth. And it doesn't matter how tight your control is, you have this risk, so we need to take baby now. And like I said, the risk is associated with the high blood sugars. ACOG, the American College of Obstetrics and Gynecology, they recommend no earlier than 39 weeks unless there is a reason. And they say poorly controlled diabetes is the reason, not diabetes.
Right.
And some of the different other organizations will say as far as 40 weeks. Most of them do not recommend going past 40 weeks, but many doctors don't recommend going past 40 weeks with a non-diabetic pregnancy. I was lucky with my last baby that my doctor was very up to date, and he said, your control is so good, I'll let you go to 41 weeks if you want. We ended up going at 40 because they had scared me, telling me how big my baby was, which was completely wrong.
That is another huge problem. Well, huge in 2 respects. But the incorrect estimations of weight. Women are scared to say, oh, but your baby's going to be huge, so we have to either induce early or do a C-section. But these weight estimates are notoriously wrong.
Yes,
they're so
and multiple
far off.
studies say this. The later term it is, the more inaccurate they are. And there is user bias. There's ultrasound technicians, if they are expecting the baby to be big, the baby's going to be big.
So they see diabetes. They see diabetes on the chart, and they say, "Oh, of course it's going to be big."
Yep.
Oh, that is fascinating.
They expect the abdomen to be bigger, and they find it bigger, even when a lot of times it isn't. I know with Adrian, my last, they told me he was going to be 10 plus pounds, and that scared the crap out of me. Because I wanted a VBAC, a vaginal birth after cesarean. And they're like, well, your risk goes, or your chances of it being successful go way down with your baby being macrosomic. Macrosomic means that the baby is too big. So they made me sign a waiver saying your baby is macrosomic and this is going to fail, basically. So I signed it away.
And how big was he?
He was 8 pounds and 12 ounces. Which is big, but not macrosomic. And I pointed that fact out. Like, that's not macrosomic. And he was also 21.5 inches long. My brother is close to 7 feet tall. All the men in my family are 6'3" or above. I'm 5'9", being the shortest in my family. I was not going to have a little baby. So
right. Yeah. I'm the exact same way. I'm 5'10", and my babies were 8.5 pounds, but they were born a little earlier. So, and that's just how long my body wanted to carry them. So, but that is fascinating. So, okay. So doctors are saying that the mothers should not be carrying their babies full term, or diabetic mothers should not be carrying babies full term, because either they're macrosomic and they're going to be too large, or there will be placental issues and they need to be induced or brought in for C-section earlier. Right. But the case is that the high blood sugars cause placental issues, and it is not diabetes.
And if you do not have normal blood sugars, then absolutely take every precaution. I'm not, off the handle saying, oh, go to 40 weeks.
True,
I'm saying,
absolutely, yes.
If blood sugars are normal, you can almost definitely go to 40 weeks. But if your blood sugars are not normal, then by all means, go at 37, 38 weeks.
Well, all of this is about taking control of our health through low carb. We are both low carb advocates, and achieving normal non-diabetic blood sugar levels through that. So, okay. Now, we had a conversation about this previously, and I just wanted, since we're talking about the placenta right now, I just wanted to touch on that. You were educating me on all of the different ways that the placenta can be checked. If you are being bullied into saying, oh, there are placental problems and we need to induce, what are the different ways that women can ask for their placenta to be checked to avoid any bullying at this point?
I'm so glad you reminded me, because
when you're approaching,
this is the thing I see over and over and over and over, and I've seen it for 16 years. I'd probably say 90% of the type 1 moms I've seen experience this. But somewhere between 34 and 36 weeks, they see this dramatic drop in insulin needs. And the doctor says, oh no, your placenta is failing. We need to take the baby now. And a lot of times they'll do an emergency cesarean section saying, this is an emergency. We need to get baby out because your placenta is failing. When in fact, this can be very, very normal. I do want to say, by all means, check. Find out if there is a problem, because I wouldn't want to risk baby.
Absolutely.
But yes, you can check. They can use Dopplers to check the blood flow to and from your placenta. They can look for calcifications on the ultrasound on the placenta, and they can also do a blood draw for something called human placental lactogen, which is a hormone the placenta makes, and that's what causes the insulin resistance during pregnancy. It's to make sure baby gets enough glucose. So it's making you insulin resistant so that you have more glucose in your blood, which is shunted to baby. And a lot of times, if that hormone drops, there's an indication that there is placental problems. So they can test your blood for that. So you don't have to just jump the gun and do an induction because your blood sugar, insulin needs have dropped. I experienced that with all 3 of my babies. I was expecting by the last one, I'm like, well, I'm about 35 weeks. This is going to happen. And sure enough, it did. I was very lucky in that all of my perinatologists, they were aware of this. They were like, it's normal. Don't worry about it. They were monitoring baby twice a week. We were doing non-stress tests, biophysical profiles. I was doing kick counts, which I think they're kind of shying away from the kick counts now. They say, you should know how your baby moves, and if your baby's not moving how it should, then you need to get checked. So monitor baby, monitor their placenta, but don't let yourself be bullied into an unnecessary induction or cesarean just based on decreased insulin needs.
Well, and that's something that you have seen everywhere, time and time again. This is a common theme for most women.
And don't get me wrong, it does happen. Placental deterioration does happen, but it's not always.
Right, but there are ways to ensure that you know what's happening, and you don't just have to take that decrease in blood sugar levels as that there's a placental problem.
Right.
Fantastic, thank you. So as you were telling me this the other day, I was very surprised. It's been quite a few years since my last one, and I had no idea about these things. Okay, and that was number 3, the myth that early induction is necessary with type 1 diabetic women. And that is absolutely not the case. Number 4, all type 1s will have macrosomic babies. That's something that we've both been told, and I was told by everybody when I was pregnant, saying, "Oh, but diabetic women always have such big babies."
Yeah. So macrosomia happens again because of high blood sugars. When your blood sugar goes high, baby's blood sugar goes high, and baby's making its own insulin. So it brings down its blood sugar through its own insulin. And insulin is a fat storing hormone, which we know about. So baby's blood sugar is high, it makes more insulin, it gets fat. We see these little chubby cheek, we call them cherub babies. So they're adorable. But I can look at a baby and say that's a baby of a diabetic mom because they just have those little cherub cheeks. But again, it's due to high blood sugars, and it does not have to happen. My first baby was 7 pounds, 1 ounce, and she was not fat at all. Number 2 was 8 pounds. None of them were big babies, or not macrosomic babies, I should say. Yes. I never had little babies.
Well, like you said, that is her hereditary size, and and if you
I've seen so many, and especially in the GRIT pregnancies group, we have a group of normal pregnancies, healthy babies. They're full term. You're not seeing all the problems I see in the mainstream groups. We're not seeing the macrosomia. We're not seeing the respiratory distress. The low blood sugars. Baby has low blood sugars when it's born. That's very common. My second baby was that way.
And preeclampsia and those types of things go along with it.
Yes.
That is so good to hear.
And it happens sometimes.
Absolutely. There are always going to be outliers to any situation, but I think it's so great too.
The differences between the mainstream groups and the GRIT group are just night and day. It's just crazy.
And the GRIT group, for anybody watching that doesn't know, it is a dedicated low carb diabetic pregnancy group.
Yes. And basically we take anybody type 1, type 2, pre-diabetes, gestational diabetes, even if you're insulin resistant, I'll generally let you in. So, and if you're a member of the type 1 GRIT group, you're immediately.
You get automatic membership, right? Oh, that's great. Thank you. I just love hearing those stories it just shows you the power, it shows everybody the power that normal blood sugars can bring to us. And
I get so excited whenever somebody has a healthy baby and I show everybody my pictures. Look, another great baby. It's so exciting.
Oh, that's fantastic. All right. So, you just touched on this. Our number 5, that all babies of type 1s will experience hypoglycemia. So tell us, you already touched on this a little bit, but if there's anything more you can share about hypoglycemia in newborns.
Well, like I was saying before about when mom's blood sugar goes up, baby makes insulin to bring it down. So it gets used to having a certain amount of insulin on board. So then when mom delivers, all of a sudden that supply of glucose is cut off when the umbilical cord is cut and baby's not getting the glucose, but it's still making the insulin it was making before. So it's going to have this big drop in blood sugar level. Now with neonates, blood sugar is a good bit lower than it is in an adult or even a child. Like a neonate can have a blood sugar of 40 and it's still normal.
And that's another thing that I think a lot of people don't know. They see that the baby has a blood sugar in the 40s or 50s, and of course, a 40 or 50 is a severe low blood sugar for an adult, but it's not for an infant.
So yeah,
Mhm.
like I said, with baby number two, what had happened is they made me take my insulin pump off during my C-section,
Mhm.
and they didn't give me an insulin drip because the doctor was so sure that as soon as that placenta was out, I was going to go low. And he was so scared of lows, he did not put me on an insulin drip. So I was probably close to 150 when the baby came out. And from studies I've read, if you're above 110 at the time of delivery, there is a good risk that the baby is going to be hypoglycemic. So he was, and he ended up having to have an IV of dextrose to bring his blood sugar up. Whereas my other two, blood sugar was normal at birth. They did not have hypoglycemia. And I had this particularly snarky nurse who was like, he is going to have hypoglycemia when he is born. And I'm like, oh, no, he's not. And he was like 60. And I just kind of looked at her and she didn't say anything.
Well, I am glad you showed her that there is an alternative to that. So,
Right. Now,
oh, that is great. Okay.
Again, there are outliers, and it is not always caused by high blood sugars. I mean, there are various reasons. Some babies just don't adjust as well when they come out, and they'll have a low blood sugar that will typically go away right away with breast milk or colostrum. A lot of the moms in my groups collect their colostrum as the pre-milk you make before your body starts making milk, and they'll save it in little syringes to feed the baby in case of low blood sugars. I think that's a great idea.
That's fantastic. I am definitely a low intervention advocate, if at all possible. So that is wonderful. I love that. Okay, so those are our 5. We have a bunch of questions that are coming in, and I want to address those, but I just want to review what we talked about already. Our 5 myths that we were just discussing were: the first myth that all type 1 pregnancies are inherently high risk. Number 2, that mother and baby need carbs during pregnancy, baby for growth. Number 3, that an early induction will be necessary, which we got to talk a lot about that. I love some of the discussion about what you can do to check the placenta, because that is a big question that people don't know about, and we want to avoid bullying into a C-section or a induced labor if at all possible. And then number 4, that all type 1s, or all diabetic pregnancies, I should say, will result in a macrosomic baby.
Oh, and I want to interject right there.
Yes.
I forgot earlier. A lot of, even if you do have a macrosomic baby, a lot of the doctors will say we need to induce because the baby is big, or you need to have a cesarean because the baby is big. And according to ACOG,
ACOG is the American College of
Obstetrics and Gynecology.
Okay, thank you.
They say that macrosomia is not an indication for induction. And macrosomia is not an indication for cesarean section unless the baby is greater than 5,000 grams, and that is a big baby. I'm not sure exactly, but I think it's over 10 pounds. So
I'm
big.
trying to do my conversion here.
My math is not that good, but I remember doing the math at one point, and it's a very big baby. So
okay, well that is good to that's good to know in itself. That
it's not an indication. Women can deliver big babies. A lot of women, can deliver 11. I've seen people deliver an 11-pound baby and not even tear. So it's definitely possible.
Oh, that's fantastic. So empowering to know all of these things. I wish I would have known these a long time ago. But okay, and then the last one that we had talked about was about type 1 babies experiencing hypoglycemia, and that is not the case. Now, we have a question that came through from Bethany here, saying that my endo is telling me I must eat carbs to prevent ketones, which will harm the baby. How true is this?
So, hang on, I've got a really noisy child. Hang on 1 second.
Yes, absolutely. Talking about babies that grow into kids. Oh, thank you, Crystal. 5,000 grams, just over 11 pounds. That's perfect. That definitely helps.
Sorry about that.
No, I was just saying, all this talk about babies that grow up into lovely children.
Yeah.
Before we get into that, Crystal just chimed in here saying that 5,000 grams is just over 11 pounds.
There you go.
So
that's a big baby.
Okay, so getting back to Bethany's question about eating carbs to prevent ketones and that ketones will harm the baby. How true is this?
So that question was also breached to Dr. Bernstein in one of his diabetes and pregnancy episodes. And again, he said utter nonsense. We evolved on ketones. Pregnancy is a especially ketotic prone state. Even non-diabetic women are going to have ketones in pregnancy. And especially if they have morning sickness and they're vomiting, they are going to have ketones. And also there have been studies on newborns, and there are ketones present in the newborn's umbilical blood. They thrive in a ketogenic state. I think where the question comes in is studies or doctors' experience is seeing women in diabetic ketoacidosis. That is very dangerous, and that will hurt your baby. But it's not the ketones in and of themselves. It's that acidotic state that is so dangerous. To my knowledge, there have not been any studies on nutritional ketosis in pregnancy. All the studies have been either starvation ketones, and if your mom is starving, that's not going to be good for baby.
Right.
There are women in third world countries having high ketones because they're starving. Yeah, that's not good.
Yes, it's the malnourishment that's an issue there.
And then, of course, DKA, that is going to harm baby. I actually had an incident with my last pregnancy where my pump was dislodged while I was asleep, and I woke up with high ketones, and baby was looking bad on the monitor. Fortunately, we were able to get my blood sugar back down and normalize everything, but things can go very bad very quickly with DKA. But again, there's a big difference between DKA and nutritional ketosis. I will also say that Dr. Bernstein's program is not a keto diet.
It's a very good distinguishing factor there.
I've been eating this way for 10 years now, and I don't make ketones. Or when I test my blood, I test my urine, I don't have ketones. I would say if you have ketones, to try increasing your protein if you're uncomfortable with them. I'm not saying that they are dangerous, but if you are uncomfortable with your ketones, eat more protein.
And some people really do like checking ketones and making sure that they are producing ketones with low carb, and other people are fine not to test, and ketones aren't really a goal. And that's one thing that Dr. Bernstein says, that ketones aren't a goal, normal blood sugars are. Exactly.
If you look at the Type 1 Grit Pinterest page, it's pinterest.com/type1grit. We have a whole section on pregnancy, and there's a lot about pregnancy and ketones there that you can read the different studies and articles.
Oh, perfect. Thank you. That's a great resource. Okay, and now Danielle. Hi, Danny. She says, what target A1C would you recommend getting to or below for pregnancy?
I will tell you what Dr. Lois Jovanovic said. Lois Jovanovic, she just passed away about a year ago. She was a revolutionary in diabetes and pregnancy, and she promoted low carb. And I use her pregnancy book now to give advice. She said, your A1C needs to be the same as your non-diabetic partner. And she would test the husbands. She would bring them into the office and test their A1C, and she'd say, okay, he's 5.3, you need to be 5.3. And
wow,
that's basically what I say. You want to be in the non-diabetic range, absolutely less than 6.
Thank you. All right, perfect. Tough one, especially if you're coming from higher, but you yourself are a testament that you can do it, and you can get your blood sugar down, particularly quickly if you have the motivation, with pregnancy to do so. I know a lot of
life being at stake, that is a huge motivation. You think I'm doing my very best and there's nothing else I can do, but when you get those 2 lines, things just change. It's like, oh well, I'm going to test 15 times a day.
Now you really are doing it for 2. You're eating for 2, but in a very different way.
Yes. So. I like that. I have to remember that.
Good. And then there was a question about VBAC that you are very passionate about. And it said, I've had 2 C-sections in the past, one because they were measuring my baby at almost 10 pounds, what we already talked about. He was actually 8 pounds, 12 ounces. Second baby came out at 35 weeks at 7 pounds, 14 ounces. My question is, how true is it that I need to have another C-section because of the risk of having a big baby? My A1C is 5.9% now. Can I avoid a C-section if I keep my blood sugar in check?
that is going to depend on your doctor. That is the biggest thing. Besides keeping your blood sugars normal, your chances of having a successful VBAC are finding a VBAC friendly doctor. And that can be difficult because they're so terrified of the risk. But a lot of the doctors aren't even really informed correctly about the risk of uterine rupture. I know mine told me, well, the risk is 3%, and that's not true. The risk is closer to 0.5%. So finding a VBAC friendly doctor, you can look at your local ICAN chapter. That's ICAN. I think that's International Cesarean Awareness Network. They're helpful at finding VBAC friendly doctors. I actually just Googled VBAC friendly doctors near Savannah, Georgia. That's where I was at the time. And this MFM doctor popped up, and that's who I ended up being referred to, thank goodness. If you have a doctor who says, well, you can VBAC if, and they give you a long list, they're not truly VBAC.
Run away, find somebody else.
You can go into labor naturally by 38 weeks if the baby is not too big. If this, and this, it's probably not going to happen. So the biggest thing you can do is finding a friendly provider and then keeping your blood sugars normal so you don't have a big baby. 5.9, I would say, is on the high end. I would try and bring that down a bit if you can. But I have seen normal sized babies at 5.9. So it's definitely possible. I had 2 cesareans and I had a vaginal delivery and everything was normal. No complications, no NICU time, no nothing. Everything was great. Yeah.
That is so great to hear. And I know that's what a lot of women need to hear, these successful stories. So thank you. Danielle asks, what was her name again of that author? I believe she's asking.
Lois Jovanovich.
Lois Jovanovich. Okay.
Jovan.
We'll get her name posted in the comments here afterwards, and maybe a link to her book. So.
And Dr. Bernstein refers to her often when he's asked about pregnancy and female reproductive menstrual cycle issues. He's like, well, this isn't really my area of expertise, but I recommend Dr. Lois Jovanovich. And I'm so sad she's no longer with us.
Well, thankfully, she wrote the book. So thankfully, we have her words that we can refer to. So that is fantastic. And if there are any other questions, we would love to field them here while we're still here. Maria chimed in and said that both of her kids were born at 39.5. Second was a VBAC. They were 6 pounds, 11 ounces and 7 pounds, 11 ounces, no complications. She ate approximately 30 grams of carbs per day and kept her A1Cs in the low 5s.
Beautiful.
Congratulations, Maria. That's amazing. We love to hear those stories. Well, it doesn't look like there are any other questions here. Anything else that you want to add, Allison?
I think we've covered the major, but keep your eye out for my book because I'm going to try and answer every question I can possibly think of. So. And
let's reiterate what those diabetic pregnancy groups are that you would recommend. GRIT Pregnancies.
GRIT Pregnancies and Positive Type 1 Diabetic Pregnancies.
Fantastic.
Positive Type 1 Diabetic Pregnancies is the mainstream group. It is not low carb, and GRIT Pregnancies is the low carb group.
Okay, wonderful. Oh, here's another one. Thanks so much for answering. Let's see, regarding ketones. Yes, it is hard to stand up to doctors sometimes, especially Bethany was writing from the UK where they don't have a lot of choice. You are assigned to a doctor and that's who you get. So yes, this whole webinar, this whole idea, all of the work that that Allison is doing here is really to empower women to know what their options are and to have create the best outcome possible.
Yes.
Well, wonderful. Thank you so much for everybody joining us. Thank you to Allison for sharing your fantastic information here. I'm really happy that we were able to talk about this. There is such a need for this type of discussion within the diabetes community and showing that we can take control of our health, particularly during pregnancy. So we are going to be watching out for your book, and I think you're going to have some new people joining your groups here too.
I hope so.
Well, thank you, everybody. We will be back again next month for another Facebook Live with Allison. We will be announcing the date, usually about a week ahead of time. And so we will see you all then. Thank you so much. Thank you, Allison.
Thank you.
We'll talk again soon. Bye-bye.